Welcome to Value-Based Voices, a podcast from the Association for Value-Based Cancer Care. Each episode dives into the shifting terrain of cancer care in the United States, exploring what value means in today's clinical, policy, and patient-centered environments. Our mission is to spark informed dialogue, promote transparency, and equip every stakeholder from payers to providers to patients with the insights they need to navigate cancer care with clarity, confidence, and purpose. So let's get into it. My name is Sarah Alwardt. I am the President and Advisory at Avalere Health, and I will be your host for today's episode. With me is Jeff Patton, CEO, One Oncology, and today we'll be talking about consolidation versus independence in cancer care. Welcome, Jeff. Thanks for joining us.
Thank you.
This is a topic you know something about.
A bit.
You kind of live with it every day.
I do.
Awesome. Maybe first question. What comes to your mind when we say consolidation versus independence, consolidated versus independence? Maybe we start there for the audience.
So that's a great question because I don't think they have to be versus. So in the One Oncology model, we consolidate and aggregate practices, but they stay independent. They still retain their tax ID. So they're independent, but they're aggregating purchasing and back office and other operational functions. And so they benefit from economies of scale, but they're still independent. They still own their own tax ID. They're partners in their business. They run their business. We just help them.
Do you think when people say consolidated, they're thinking private equity owned companies came in and swooped up and bought a bunch of practices? Do you think there's some of that comes from? Because I agree.
For sure. And there are such things as roll-ups out there. And when people compare us to a rollout, I get really mad because, roll-ups aggregate a few practices into an MSO, but they don't really build out much functionality in that MSO, and they're trying to do a financial arbitrage, and it's a rollout. We are not. We're a sustainable model that's built on a model that has been around for over 30 years. So our competitor and what's the old saying that imitation is the best form of flattery. So our model is built very similar to U.S. Oncology. U.S. Oncology has been operating this model for 30 years. That's not a roll-up. U.S. Oncology is not a roll-up. One Oncology is not a roll-up. And so we did have private equity backing, but ours was growth equity. They got a nice return. We grew. It was a benefit. One of the big things that private equity does bring is access to capital. Insurance companies, well-capitalized by definition and by design. Hospitals, mostly pretty well-capitalized. Independent physician groups, not capitalized. I mean, mostly not at all because they're mostly either PCs or PLLCs. Yeah. They zero out their books at the end of every year and they start the next year from scratch. That's not capitalized.
What does that let you do? What does that let you do for your practices today with that access to capital?
Grow into ancillary businesses. So if you want to get into a linear accelerator business, it's somewhere between $5 and $10 million of capital. If you want to stand up a PET CT, maybe $1 million for a center. So it allows us to diversify. Two, it allows us to grow. So our model is that we try to find a successful, clinically outstanding practice, and we call it land and expand. And so we affiliate with them, and then we help them grow in their market. Well, to attract two doctors here and recruit a doctor there, that can be dilutional if you don't have access to capital. So we bring capital to protect them from the dilution that growth could encumber and enable them to grow. And healthcare. Healthcare is local and it's about market share. And so he or she who has the most market share, whether it's the hospital, the insurance company, or the independent provider, you have to have enough market share to have a voice.
I would say that when you talk to people about what healthcare means, they'll say health, and health is good, and it's warm hugs, and it feels all nice, and care is loving, and all of that. And then you put them together, and you go, all of a sudden. But how often are you protecting against independent or community being bought out by hospitals in that consolidation?
A lot. And so if you're in a market and you don't have scale, and the government's paying you less every year, so your profitability is going down. And if you're not getting rate or decreasing rate from your commercial contracts, you're at risk of going out of business. Your choices are someone like us or a hospital. There's not a third option really. And so So that's one case where we're protecting, and they should have that option. Like if they want to join a hospital, great. I don't like it when there's not a community or independent option in a service area. I think every patient should have the option to choose a hospital, academic medical center, or a community center that's close by. And so we have been able to protect, and then we have actually. This will sound harsh, but we call them extractions. So we have taken full practices that were independent, joined a hospital, had that experience, and decided that wasn't the
left it otherwise.
It wasn't the perfect experience for them. And often it's when that contract's up, the next contract is offered not in the same spirit as the first one. And so we've 6 different times we've taken groups that were hospital-based and stood them up in a community practice. That takes a lot of capital. They could not do that on their own. You know how the payer works.
How do they get through that transition? I would say that would be, because those are 2 tough transitions for a practice, I would think. How do you help them through that?
I mean,
culturally, financially, all of that.
The culture is probably the easiest because they go, at least coming back out, they go from, an employed, Dr. Widget model to we stand them up and we make them independent. They work for themselves with our help. And then we have the operational expertise to do the contracting, find office space, hire their staff. I mean, it's a lot. You're paying bills day one. You're buying chemotherapy day one. Payers aren't paying you for
not day one.
30 to 90 days, and
30
so
if you're lucky,
that
probably.
Working capital is and you know how expensive chemotherapy is. So the working capital it's just not something they would do without the financial resources that we have and the expertise. Quite frankly, it's a little daunting. But now that we've done it 6 times, like we know how to do it. Now, starting from a brand new tax ID, that's really hard. Yeah. If we have an existing practice that they come and join,
they can join.
That's a lot easier. That's a lot easier.
I was going to say there's probably has to be a couple different versions of that, depending on who you have in that market.
For sure.
To kind of adjoin or stand up completely new.
That's right.
I think financially, the consolidation is definitely a good option for getting scale. How are some of the pressures? I'm a consultant, spend a lot of time thinking about policy. Inflation Reduction Act. How are some of these more political or policy existential threats impacting?
It's yet to be known, as you know. I don't yet know. What I say, and I get this question from the providers all the time. They're like, "What if?" I'm like, "Well, let me tell you what. The reason we're here today is that your margins are at risk, and so if you need us now, if that is catastrophic, you're going to need us more. And so if you look at the airline industry, the distribution business that's adjacent to us, there's only X number because if there's limited margin, you need scale, and healthcare provider margins are decreasing. So if you don't have scale, I don't know how you survive.
What would you like to see happen?
I would like to see, so there is an unlevel playing field right now. I'd like to see the playing field a little more level, and I would like to see incentives a little more aligned. What do I mean by that? Hospitals get paid a lot more than we do. Not just on the commercial side, on the government side.
Very different billing just across the board.
It's just not fair. So level the playing field. I say this on stage. I'll probably say it later today. If healthcare was a free market, community oncology would have won a long time ago. Our outcomes are at least as good. Our patient access and accessibility and experience is lots better than going to a hospital. And we do it for about 1/3 of the cost on the commercial side and for about 90% of the cost on the government side. So there's not many places in a free market where that equation doesn't win.
Yeah, that sounds like a pretty good math there.
Yeah, it's pretty simple math.
For this conference, we're talking about value-based care and oncology. That's been a tough nut to crack, I think, over the last couple of years. How do you think about that today? How do you think about that moving past today? What is the future of value-based care and oncology?
I'll answer that question with the same theme I just talked about. If there is a site of service differential where we can provide care less than half the cost, and that's not the needle, if that's not moving the needle, tell me a value proposition that's going to move the needle. So again, until the incentives are aligned, I don't see, there's value-based care going on out there. I call it enhanced fee for service. Yeah. Like someone's like 90% of our contracts are value-based. Really, tell me about that. What percentage of your revenue is based on value or is it fee for service? It's all fee for service. There's almost no one out there taking full risk.
Not on both sides.
And it's just, so how do you define value? Now, if you want to define
That's
value,
where I was
now,
my next
now if you want to define
My next
value
question.
as outcomes and patient experience, like we
That
can
next
compete on those things. But if you're just talking about the economics, like we have a value proposition that if you have a lever that will save 70%, let me know what that is, because I want to invest in whoever's doing that. I have a great value-based proposition that, site of service. It's happening in surgery centers, like like they're getting traction. It's the exact same concept. Like they're providing surgeries at a better patient experience at about a third to 50% of the cost. And the surgeries are moving, but chemotherapy's not. And we can talk about why that might be.
I was going to ask value to whom, because that's always my favorite next question.
I have to agree. It's it's like fairness. It's in the eye of the beholder. So value to whom is like, so right now, I think that the TPA insurance companies they're just fine with how things are going. I don't think the employers are fine with how much it's costing, but they don't really know how to get there. And so we're kind of stuck.
It is a very interesting model. We get very accustomed to getting the actuaries in a room and doing all of the math and getting very comfortable with a number that isn't necessarily value to anyone, but we're comfortable with the math, so therefore
it's predictable.
It's okay.
I mean, and I get, like, if you're underwriting something, like you need predictability.
Yeah.
I'm trying not to be as judgmental as I'm thinking.
Yeah. Well, one of the challenges that I've had trying to figure out, I'd love your thoughts on this, is understanding and how to quantify, because dollars are going to need to be included in the math somewhere, but how to really quantify patient value, because that experience intuitively, I would say, leads to better outcomes, better quality of life, and then valuing that in dollars is hard. I'm curious your thoughts on that, because I think that that's where community really it has a tremendous opportunity of keeping people at home and keeping them in their, with their families.
Yeah, and I think until you level the playing field, I don't know how we'll know. Like that's why I like a free market where you see by choice. Like people buy an Apple phone because that's what they want. I think if it was a level playing field, I think people would choose our experience. But how do you prove it, and how do you quantify it? And then it's going to be, an eye of the beholder again.
Yeah. Maybe along the same lines, I spent time talking to pharmaceutical manufacturers, some in very early development. One of the things that's come up several times now is how to include community in like cell and gene therapies and in the trials very, very early, where those tend to go to other places, go to academic medical centers. And if they go to academic medical centers, they don't figure out how to do that in the community, and then they don't, and you're stuck in a situation where you've got someone needing to leave their home to go to a medical center, and your mom at home, 3 kids, 70 miles is Mars. Yeah. So it's and so then they're going to forego what could be an innovative therapy. I'm curious your thoughts on, like, if we were to aim the conversation to the manufacturers listening today on what they should be thinking or what they should be doing differently in early development, because by the time you get to your later phase trials, it might even be too late. But what advice would you give that audience?
Yeah, so I have studied this over the years as well. I call it technology adoption. How does technology get adopted, and then how does it diffuse? And it always does. Cell and gene is a challenge. One, because it's very expensive, more so than the others, and two, because of the toxicity profile, you have to have a hospital partner. So one of our practices, and now 2 of our practices, has stood up and are performing CAR T therapy in the community as predominantly outpatient, but they have to have a hospital partner. So if you think about it, you've got an independent practice, you've got a hospital, which is not the easiest, you've got big pharma, not the easiest to navigate, and a payer. So you have 4 parties that have to agree on this.
You got a perfect storm there.
Exactly. And so the key's going to, and it will happen as the toxicity profile improves, and it can just be done as an outpatient. Then it'll happen. It'll be adopted. The bispecific is probably the next iteration of that. Yeah. And so you can ask the folks at Amgen. One Oncology community-based practice is the highest utilizer of their small cell lung cancer bispecific. So if it can be given safely in the community, we'll give it, and then it will diffuse.
You engage the community in the trial, so you're going to get adoption and uptick and all of that. It just is it's a tremendous thing. Like looking at older data, if you have the trialists and they're doing the trials, they're going to use your product.
Oh yeah, I mean
the advocacy of that.
I've shared this because we've done a lot of clinical research over our days, and the halo effect for how well your commercial launch is going to go. If the doctors already are comfortable with it, already using it, like they're going to use it day one of launch. If they've never seen it or thought of it, and it has some weird toxicity, it's going to take a while.
1,000%.
So the halo effect, there's a significant halo effect that I wish they would value that a little more. How do you pass that value down?
It's exactly right. But it's like the conversations that it's funny because I'm a data will save the world person. So you start to take a look at addressable market and like where are your populations? Who are your people? Where do we think they're going to be seen? Where are they being seen from past history? All of that. And you would present that to some of my clients, and you're like 60% of your population is going to be in the community, but you don't have a commercialization plan for how to engage the community.
Yeah.
What were you thinking you were going to do there? And if you say it at the very last, I mean, I've heard some wackadoodle things from some clients, like we're like, this is our strategy, and I'm like, yeah, but your strategy isn't smart.
Yeah, that's not. Yeah.
And I get to
Hope is not a strategy.
No, and I get to be a consultant. And I can say these things out loud.
They're paying you to say it.
Exactly. It was like, so that's
nice.
generally really good. But at the same time, it's like if you had thought about this 18 months ago, or even 2 years ago, you would have had a very different approach, very different world. So I think that there's some underlying, like, how we get some of that message out, and I'm a huge community advocate, so it's like that comes through in some of the consulting that we do.
You'll get this right away, and so companies have been in oncology for a long time, and they understand that buy and build mentality. Like, they get it. But I call them the big pill pushing pharmas that then get into oncology.
Oh yeah.
They don't have a strategy.
No.
They just think, well, we have the best drug, and it'll just jump off the shelves. It's like it's a little more complicated than that.
No, it is. We could write a book.
Yes, we could.
Because some of the things I have heard said on, like, yeah, but you've been doing chronic cardiovascular disease.
It's not the same.
It's not the same. It's really different. This is rare disease, and we tend not to think about cancer as rare disease because it is prevalent, but it's still rare comparatively, right?
Yeah, well,
so
yeah,
it's
for
like,
sure.
And then you get like
and it's so nuanced, and it's at least 1,000 diseases.
It's, I mean, like 80 of them
diabetes
just
is
in
a
non-small
disease.
cell lung cancer.
Yeah, that has lots of sequelae. But yeah, exactly.
So it's a little bit different world, and even having some of these very interesting conversations up front just ends up being just enlightening on some of the kind of the bias or the nuance or just the kind of the misinformation kind of coming in. So we spend a lot of time trying to educate on how to get better engaged.
They just don't understand the barriers. And CAR T is a perfect example because they are
That's
struggling.
The latest. It is, for sure.
But it's hard. I mean, it's you have 4 stakeholders, and you're only one of them. You can't just wish it to happen.
We did a study recently, and it was, there was a misconception that it was like, well, the oncologist wants to keep the patient because if the patient goes to the academic medical center, then they're gone forever. And we started talking to patients, and it's like, no, I can't go. I can't afford to do this. I can't afford to leave my family. I can't afford to go the 200 miles or whatever to this other place because my doctor is here,
or my cows are here.
Exactly. Like
literally,
the rest of my life is here. I can't do it. And while many of us even listening to this would have the benefit of going wherever we would want to go, wherever in the world we wanted to have treatment, like, that is not a choice that most people can make. It's
not. And you probably have data on this, but so we've done surveys of the number of people who are living paycheck to paycheck. It's the majority are you know what? It's also the majority of people that work for a hospital or work in a medical office.
It's true.
It's paycheck to paycheck.
It's true.
So if you're paycheck to paycheck and you get some little wrench, what are you going to do?
It's incredibly devastating, and definitely spending time thinking about. It's where my question came from on patient value and really understanding, what's important to patients and really how to value that as part of the conversation. I think is interesting.
What I'll say is, and one of the beauties that we feel about community-based oncology is that our focus is on the doctor first. Because the doctor is the only one who's stated a Hippocratic oath and really the main advocate for the patient.
Mm-hmm.
And so if you enable the doctor to have every tool he can, he or she will do the right thing. And that should be a winning strategy.
I think so. Talk about data for a second. Like I said, data will save the world is my favorite topic.
I like data.
How do you guys use data? Talk about data.
So we have what's the latest? I used to call it a data warehouse. Now it's a data lake, I guess.
We have data oceans,
a data
lakes
ocean. So
like...
all of our molecular data, we have direct feeds from all the testing companies.
Fantastic.
We have all of our EMR data. We have all of our data in our data warehouse, and then we purchase claims data. And so we have at One Oncology. It's one of the big different. Like you could never do this as a practice. We have 20 data scientists on our team that use our data ocean to analyze, and so we can do KPIs. We can find, so if there's a molecular defect that's not actionable that you tested for 2 years ago, and now there's a commercial product that chooses, we can identify those patients and email the doctor and say, you have 6 patients that qualify for this therapy.
That's amazing.
We use a lot of data.
That's amazing. I love it. It's been the frontier that we've gone through the last couple of years, and just unleashing, especially with the molecular data.
Yep.
For a long time it was you would get a fax. I always was wondering who was using fax machines, and it was because we were using fax machines
and medical offices. We still
medical offices. Yeah, exactly. It's really the craziest thing to even say.
It is.
But unlocking some of those data when it was just in a faxed piece of paper was just unthinkable even a few years ago. So that's amazing progress. And
when I was at Tennessee Oncology, when we decided to form One Oncology, it was one of the use cases I said is that we will never, like, at that time, 7 years ago, we thought you were going toward population health. Like at that time, right? You did too, as a consultant. Like that's where we're going.
For sure.
And if you can't manage your data, you're not going to. So I'm like, we can't afford the data analytics that we need to be successful. Mm-hmm. Well, that didn't come true, but we still need the data analytics, and with AI, it's going to go even more, and it's going to explode.
Yeah.
But it's still like it's not going to happen for free,
no.
and so you need those economies of scale and access to capital to do the right thing.
I think that's one of the biggest advantages of some of the community models that exist today is just unlocking some of the data that are there, because you would independent, completely. Rural Tennessee independent. You're not. You're going to use the data you have in front of you on that day, and that's the best you've got, and it's not enough. I'm curious. Maybe one of the things that I think a lot about is that time to treat, time to diagnosis, partnership with pathology. Have we cracked that nut yet?
No, and it's because again it's siloed, and so we at Tennessee Oncology employ pathologists, and if it's a blood sample, like we can do that ourselves, we have access to it. But if it's a biopsy that's done in a hospital, they don't work for us, and they almost see us as competitors. And
getting that block is...
Yeah, exactly. And so no, we have not. It's not seamless. Just like we don't share data seamlessly, there are so many barriers out there. Again, the world comes down to incentives. Behavior follows incentives, and as long as we have misaligned incentives, we're not going to have the best outcomes.
It's one of those things that I talk about data democratization, and a lot of people make a lot of money in data, so that's going to be a tough thing to overcome. But even thinking through what we could do if systems talk to each other better, we have like government, like HIPAA, HIPAA. I guess it's a good thing, but it's often a bad thing. Like it gets in the way. It gets in the way. That's why we still have faxes, by the way. Tennessee Oncology gets tens of thousands of faxes every month. If a new patient comes in, all that info comes by fax. It's incredible. It's incredible.
I was on a panel this morning with a colleague, and he's probably 10 years younger than me, and he was talking to his daughter who's in college, and she asked him what a fax was.
Well, no one's seen it. Like
They're not
the Gen
anything.
Zers. I know, it's terrible. It's like it isn't good. We're not proud of this.
No,
but when
not.
I think about like who is still using fax machines, it's oncology office, doctor's offices,
primary care options,
pharmacies, specialty, getting scripts through. It's an amazing thing.
It's HIPAA compliant.
What did we miss talking about? What did we miss talking about today?
I guess that what does it mean for the future? And so and I talked a little bit about barriers. And so so for at least in oncology, the biggest barrier to a level playing field is 340B pricing and the abuses of 340B. We're good, but we can't compete with 500% margins.
No, 340
on our 10% margin. Like that's just not going to work. So until you level the playing field, it's hard for every patient to have that choice. Every patient deserves a choice. So I'd like to see a little more leveling of the playing field.
I've heard the math ain't mathin' sometimes.
That sounds like somebody from the South. I may use that one. I've not heard that one. I'm surprised. I'm a Southern boy. The math ain't mathin' is true.
Oh, fantastic. Well, I think that wraps up this episode of Value-Based Voices, brought to you by the Association of Value-Based Cancer Care. Heartfelt thank you to you, Jeff.
Thank you.
For sharing your insights today, and to you, our listeners, for joining the conversation. If you found today's discussion thought-provoking, be sure to subscribe to the Value-Based Voices wherever you get your podcasts. Stay tuned for more episodes that spotlight the voices shaping the future of oncology.